Let's move into the final step of the diagnostic algorithm, staging and prognostication. Now, this is more than just categorizing disease. It's about determining the trajectory of cardiac amyloidosis and informing your treatment decisions with precision. Proper staging helps estimate survival, guide therapy intensity, and align expectations, especially in light chain, AL, and transthyretin, a TTR cardiac amyloidosis. So how do we approach this? It begins with biomarkers, and 3 stand out as most clinically relevant. NT-proBNP, BNP, and cardiac troponins. These give us a biochemical window into myocardial stress and injury. Elevated NT-proBNP reflects wall tension. Troponins indicate myocyte injury. When used together, and especially in combination with eGFR, they form the foundation of several validated staging systems. Figure 1 shows how extracellular amyloid infiltration disrupts cardiomyocyte function, leading to biomarker release, a key physiologic link to keep in mind as we interpret lab values. Now, in clinical practice, 2 major staging systems are typically used in ATTR-CM: the Mayo Clinic staging model and the National Amyloidosis Center (NAC) staging system. Both use NT-proBNP and troponins, but NAC also integrates renal function via eGFR. These scores are not just numeric. They've been validated to predict 1- and 2-year mortality, helping you triage patients early and tailor follow-up intensity. But serum biomarkers only tell part of the story. That's where imaging comes in, and both echocardiography and CMR are essential here. With echo, look at global longitudinal strain, myocardial contraction fraction, and stroke volume index, all of which correlate with severity and outcomes. Then there's CMR, which adds even more depth. Late gadolinium enhancement and T1 ECV mapping both quantify amyloid burden and are independent predictors of prognosis, not just in ATTR, but also in AL amyloidosis. This multiparametric model in the on-screen figure nicely summarizes how staging is evolving, integrating not only labs and strain imaging, but also structural changes, oxygen consumption, and volume metrics. So in summary, staging in cardiac amyloidosis is not one-dimensional. We're talking about a multidisciplinary, data-driven approach, combining biomarkers with advanced cardiac imaging to accurately stratify risk and guide therapeutic planning. In this section, we'll explore the evolving landscape of prognostic stratification in transthyretin cardiac amyloidosis. Now, staging a TTR-CA isn't simple. One of the biggest challenges we face is diagnostic delay, often caused by subtle early symptoms and overlapping presentations with other cardiomyopathies. On top of that, the heterogeneity of disease progression, influenced by wild-type versus hereditary TTR mutations, phenotypic variations, and even geographic and gender-based factors, complicates the clinical picture. However, one principle remains constant. The extent of cardiac involvement is the strongest predictor of patient outcomes, regardless of mutation subtype. With the rise of disease-modifying therapies, including transthyretin stabilizers like tafamidis, accurate risk stratification has become essential. This ensures the right treatment is delivered to the right patient at the right time. Let's begin with the core biomarkers. We primarily use N-terminal pro-B-type natriuretic peptide, NT-proBNP, cardiac troponins, and estimated glomerular filtration rate, or eGFR, as our foundation for staging. NT-proBNP reflects cardiac wall stress and is directly linked to disease severity. A threshold of 3,000 picograms per milliliter is used in both the Mayo and UK National Amyloidosis Center (NAC) systems. Elevated levels are associated with diastolic dysfunction, hospitalization, and increased mortality. Troponin, either troponin T or troponin 1, provides an indication of ongoing myocardial injury. High-sensitivity assays have improved early detection, and a troponin T threshold of 0.05 nanograms per milliliter is commonly used. Renal function, measured by eGFR, plays a particularly important role in the NAC staging system, helping to account for cardiorenal interactions, a common and serious complication in a TTR-CA. But how do we combine these markers into meaningful risk categories? The Mayo Clinic staging model, introduced by Grogan et al., 2016, uses NT-proBNP and troponin T to define 3 stages. Stage 1, both values are below threshold, with a median survival of 66 months. Stage 2, one value is above, survival falls to 40 months. Stage 3, both are above, median survival is 20 months. Later, Gilmore et al. 2017 proposed the NAC model, which uses NT-proBNP and eGFR instead. Stage 1 is defined by NT-proBNP below 3,000 and eGFR greater than or equal to 45 milliliters per minute per 1.73 square meters. Stage 3 includes patients with NT-proBNP above 3,000 and eGFR less than 45. Median survival in this model was 69, 47, and 24 months for stages 1, 2, and 3, respectively. When both systems were compared in a study of 172 patients, the Gilmore model showed superior prognostic discrimination, especially between stages 2 and 3. This may reflect the common presence of cardiorenal syndrome, making eGFR a more dynamic marker than troponin in many patients. Let's now move to emerging clinical variables. A study by Cheng et al. 2020 introduced diuretic dose and New York Heart Association NYHA functional class as additional predictors. When added to either staging model, the accuracy improved significantly. The area under the curve rose from 0.693 to 0.798 in the Mayo system and from 0.711 to 0.816 in the NAC model. These results support the routine inclusion of clinical data in our risk models. This image illustrates left ventricular wall thickening across the spectrum of disease. The optimal therapeutic window lies in early detection, when wall thickness is near normal and biomarkers are still low. Catching the disease at this stage improves the likelihood of treatment success and delays irreversible cardiac damage. And what about serum transthyretin, also known as prealbumin? Although less commonly used, low TTR levels, below 18 milligrams per deciliter, have been associated with worse survival. In one study, patients with low levels had a median survival of 2.8 years compared to 4.1 years in those with higher levels. Lastly, a quick note about troponin assays. Troponin T is standardized, whereas troponin 1 varies between manufacturers. High-sensitivity assays are now widely used and offer greater diagnostic accuracy, but they also require sex-specific thresholds, since some healthy individuals may show detectable low levels. To summarize, NT-proBNP, troponins, and eGFR remain the cornerstones of staging in a TTR-CA. When paired with NYHA class and diuretic burden, they offer a highly accurate and accessible framework for predicting prognosis and guiding treatment intensity. Let's talk about the role of imaging in predicting outcomes for patients with cardiac amyloidosis. Now remember, cardiac involvement is not just common in systemic amyloidosis, it's often the most clinically significant manifestation. This is especially true in both light chain and transthyretin amyloidosis. The presence of cardiac amyloid deposits directly impacts a patient's quality of life and overall survival. That's why every patient with systemic amyloidosis requires a thorough cardiac evaluation, not just for diagnosis, but also to stratify risk, plan treatment, and forecast prognosis. To do this effectively, we rely on 3 key imaging modalities: echocardiography, radionuclide scintigraphy, and cardiac magnetic resonance imaging, or CMR. Each modality contributes uniquely, but their power really shines when we combine them with clinical findings and biomarkers. Things like serum, free light chains, NT-proBNP, and troponin levels. This integrated approach enhances diagnostic precision and helps build more refined prognostic models. And as we covered earlier in the biomarkers and biopsy section, multimodal risk assessment is particularly critical when you're trying to differentiate disease subtypes and stages, and when you're tailoring therapy to an individual patient. Let's quickly summarize the prognostic roles of the major tools. First, bone scintigraphy using technetium-labeled tracers like PYP. This is primarily a diagnostic tool, but a Perugini visual score of grade 2 or 3 strongly correlates with transthyretin amyloid cardiomyopathy and may also reflect disease burden. However, it's not optimal for functional staging. Then echocardiography, particularly global longitudinal strain or GLS. It's a powerful non-invasive tool for detecting systolic dysfunction. A GLS less than -14% or an apical sparing ratio greater than 1 is not only diagnostic but also correlates well with survival outcomes and amyloid burden. Finally, cardiac magnetic resonance. With CMR, we focus on T1 mapping and extracellular volume, or ECV. An ECV greater than 40% is associated with higher mortality. These measurements allow us to track amyloid infiltration over time and are highly sensitive for early disease detection. In this figure, you'll see the value of these imaging tools side by side. Echo with the characteristic bullseye strain pattern, positive bone scintigraphy in all transthyretin amyloidosis cases, and classic CMR findings like elevated T1, elevated ECV and diffuse transmural late gadolinium enhancement, sometimes extending into the right ventricle. These patterns are highly specific and extremely valuable for ongoing disease monitoring. When evaluating cardiac amyloidosis, echocardiography remains a central tool, not only for diagnosis, but also for its growing prognostic significance. A number of echocardiographic parameters have been associated with worse clinical outcomes, and they should raise immediate red flags in patients with systemic amyloidosis. These include left ventricular longitudinal strain, early mitral inflow velocity, deceleration time, the myocardial performance index, and pericardial effusion. Among all of these, global longitudinal strain, or GLS, stands out as one of the most reliable prognostic markers. Worsening GLS correlates strongly with disease progression and is linked to increased mortality risk in both AL and ATTR cardiac amyloidosis. Another valuable tool is the myocardial contraction fraction, or MCF, a geometry-independent measurement that reflects how much volume the heart can pump relative to its own mass. It's highly correlated with GLS and can offer similar prognostic information. Even more accessible is the stroke volume index, or SVI. This parameter is routinely available in standard echocardiography and has been shown to carry comparable prognostic value to GLS in patients with AL amyloidosis, even independently of biomarker staging. But it's not just about the left ventricle. Abnormalities in the left atrium, like impaired reservoir and pump function on strain imaging, are common and can occur even when atrial size is normal. This likely reflects a combination of elevated left ventricular filling pressures and direct amyloid infiltration into the atrial wall. These dysfunctions raise the risk of atrial thrombus formation, even in patients who are in normal sinus rhythm, increasing the risk of stroke. Right ventricular dysfunction is also frequently observed. This may stem from pulmonary hypertension, but in many cases it's due to direct amyloid infiltration. Signs of RV dysfunction include reduced TAPSE, lower RV systolic velocity on tissue Doppler, and abnormal RV longitudinal strain. Now, despite all this rich information, there's currently no formal echocardiographic staging system for either hereditary or wild-type ATTR amyloidosis. That's a limitation. For now, echocardiographic findings alone are not sufficient to determine a patient's risk level. Instead, they must be interpreted in the context of other markers like NYHA class, natriuretic peptides, troponin levels, renal function, and advanced imaging such as radionuclide scans or cardiac MRI. To move the field forward, the British Society of Echocardiography recently published a diagnostic utility table that ranks various echo parameters based on their value in both diagnosing and predicting outcomes in a TTR-CM. You'll notice in this summary, apical sparing on GLS and the ejection fraction to strain ratio, EFSR, are among the most diagnostic markers. For prognosis, parameters like reduced GLS, RV systolic dysfunction, and valvular regurgitation patterns stand out. This figure illustrates how these parameters evolve over the course of the disease. Blue markers reflect early changes, green indicates intermediate stages, and orange denotes late-stage findings. By tracking this evolution, we can better understand when to intervene and which patients are likely to benefit most from early treatment. When it comes to cardiac imaging in amyloidosis, cardiovascular magnetic resonance, or CMR, stands as one of the most powerful tools we have. It's non-invasive, offers superior tissue characterization, and provides robust prognostic insights across both AL and ATTR cardiac amyloidosis. Among the most useful CMR techniques is late gadolinium enhancement, or LGE. While it has long been known for its diagnostic accuracy in identifying amyloid infiltration, early on it struggled to establish itself in prognostication due to variable acquisition methods and inconsistencies in interpretation. That changed with the introduction of phase-sensitive inversion recovery, or PSIR, a method that significantly improved image clarity and reproducibility. Thanks to PSIR, we can now trace a clear pattern of disease progression, from normal myocardium to subendocardial enhancement, and eventually to transmural involvement, a hallmark of advanced infiltration. And the value goes beyond visual interpretation. Multiple studies now show that LGE pattern and extent independently predict patient survival, even after adjusting for key biomarkers like NT-proBNP and troponin, and for echocardiographic findings. These associations hold true in both light chain and transthyretin amyloidosis. That said, LGE is not perfect. It's limited when it comes to tracking disease over time or assessing response to therapy, due to its qualitative nature and the inherent variability in enhancement patterns. That's where T1 mapping steps in. Native T1 mapping offers a quantitative approach to detecting myocardial infiltration. Elevated native T1 values are strongly associated with worse outcomes, especially in AL amyloidosis. However, the relationship is less consistent in a TTR amyloidosis. To improve consistency and comparability, clinicians now often turn to extracellular volume estimation, or ECV, which is derived from both native and post-contrast T1 values. ECV mapping has shown reliable prognostic value in both AL and ATTR subtypes, and does so independently of traditional clinical predictors. Another emerging technique is T2 mapping, which measures myocardial edema. Elevated T2 values have been linked to poorer survival in AL amyloidosis, possibly pointing to active inflammation or hidden myocardial stress. In summary, CMR is not just diagnostic. It's become a cornerstone of risk stratification in cardiac amyloidosis. With its quantitative markers, including LGE, T1 mapping, ECV, and T2 values, we can more accurately assess disease severity, monitor progression, and tailor treatment decisions. This figure visually reinforces these points by showing typical CMR findings in cardiac amyloidosis, including elevated native T1, increased ECV, and the characteristic transmural late gadolinium enhancement of the myocardium. Let's now turn to a modality that plays a crucial, though often underappreciated role in the prognosis of cardiac amyloidosis: radionuclide imaging. Techniques using technetium-labeled tracers such as pyrophosphate, PYP, DPD, and HMDP, as well as iodine 123-methiodobenzoylguanidine, better known as 123-IM-IBG, have shown strong potential in helping us understand disease burden and predict outcomes in patients with transthyretin cardiac amyloidosis. Numerous studies have demonstrated that uptake of 99-MTC-PYP, DPD, or HMDP in the myocardium correlates moderately with factors like left ventricular wall thickness, myocardial mass, troponin T, NT-proBNP, and extracellular volume. Interestingly, this uptake shows a negative correlation with ejection fraction, which reflects worsening systolic performance. Now, how do we quantify or score this uptake? Several semi-quantitative methods are available, including the heart-to-whole-body retention ratio, heart-to-skull ratio, and the more widely adopted heart-to-contralateral lung (HCL) ratio. In fact, in a multi-center study, Castano and colleagues found that an HCL ratio greater than 1.5 was associated with significantly poorer survival in ATTR patients. This prognostic insight was reinforced by Vranian et al. 2017, who showed that greater 99 MTC-PYP uptake predicted worse echocardiographic parameters and higher risk of adverse clinical outcomes. Another important point, regional variability in radiotracer uptake, meaning heterogeneous distribution across the myocardium, also appears to correlate with higher mortality. So even subtle differences in radiotracer deposition may have critical implications. That said, not all scoring systems carry the same weight. For instance, Perugini grading, though widely used for diagnosis, does not independently predict outcomes when used alone. To extract meaningful prognostic value, we need to combine radionuclide data with clinical markers such as New York Heart Association functional class, NT-proBNP, or even interventricular septal thickness. Let's also take a moment to look at autonomic imaging using 123 IMIBG. This tracer visualizes sympathetic innervation of the heart and has shown strong prognostic value, particularly in hereditary transthyretin amyloidosis. Specifically, a late heart to mediastinum ratio, HMR, below 1.6 is associated with worse outcomes and may even help identify patients who would benefit from liver transplantation. Interestingly, liver transplant can halt the progression of sympathetic denervation in some cases, although its long-term prognostic impact post-transplant remains unclear. In AL and wild-type ATTR amyloidosis, the implications of a low HMR are less well-defined, with studies showing mixed results. So what's the take-home message here? Radionuclide imaging offers non-invasive, accessible tools to stratify risk in cardiac amyloidosis. When combined with anatomical, biomarker, and clinical data, these techniques can significantly improve individualized prognosis. Key recommendations for assessment of prognosis. Multiple imaging parameters predict a worse prognosis, including increased LV mass, lower global longitudinal strain, increased right ventricular wall thickness, higher native T1 and ECV, higher HCl ratio, and 123 IMIBG increased HMR and delayed washout rate. Although not formally incorporated into current risk assessment algorithms, radionuclide results should be combined with electrocardiographic, clinical, biomarker, and other imaging findings for optimal prognostication. Now, let's explore a powerful yet often underutilized tool in the prognostic assessment of cardiac amyloidosis, cardiopulmonary exercise testing, or CPET. Widely regarded as the gold standard for evaluating prognosis in patients with chronic heart failure with reduced ejection fraction, CPET also plays an increasingly important role in the management of cardiac amyloidosis. So what does CPET tell us in this context? Well, in amyloidosis, particularly ATTR and AL types, CPET provides a window into the combined performance of the cardiovascular, respiratory, and muscular systems under stress. This is especially useful given that these patients often suffer from restrictive cardiomyopathy, autonomic dysfunction, and chronotropic incompetence, all of which significantly impair exercise capacity. Patients with cardiac amyloidosis typically display distinctive CPET abnormalities. These include reduced peak oxygen consumption, also known as peak VO2, an elevated ventilatory efficiency slope, or VE over VCO2, and in some cases exercise oscillatory ventilation, or EOV. Each of these markers provides valuable insights. For instance, peak VO2, especially when combined with NT-proBNP, is one of the strongest independent predictors of all-cause mortality and heart failure-related hospitalization. A cutoff value of 13 milliliters per minute per kilogram is often used for risk stratification. Let's break that down. If a patient has a low peak VO2 and elevated NT-proBNP, it points to significantly limited cardiovascular reserve and a worse prognosis, guiding decisions about initiating or escalating treatment. Similarly, a VE/VCO2 slope greater than 40 is associated with poorer outcomes. This elevation typically reflects a blunted autonomic response, right ventricular dysfunction, or an impaired increase in tidal volume during exertion, common issues in patients with wild-type ATTR amyloidosis. This diagram offers a concise visualization of how CPET captures real-time interaction between ventilation, perfusion, and gas exchange, providing a comprehensive physiologic snapshot of the patient. In 2025, Brazil and colleagues emphasized the central role of CPET in complex cardiac conditions, including restrictive cardiomyopathies like ATTR amyloidosis. Their work underscored that CPET is not just a test of aerobic capacity, it's a dynamic systems evaluation that reveals how different organs respond under stress. Now that we've explored the full scope of staging and prognostic tools in cardiac amyloidosis, let's bring it all together. Accurate prognostication isn't just about classification. It's about guiding when to intervene, how to manage risk, and what treatment strategies to pursue. This figure visually summarizes how different staging strategies compare in terms of prognostic value, using a relative scale from 1, low, to 5, high. The evidence shows that no single method is sufficient on its own, but used together, these tools become incredibly powerful. Key takeaways and recommendations. Biomarker-based systems, particularly the Grogan and Gilmore NAC models, remain the most widely used and validated for both wild-type and hereditary transthyretin amyloidosis. Imaging techniques such as echocardiography, cardiac MRI, and radionuclide scintigraphy significantly enhance risk assessment and monitoring, though they lack formal, standalone staging frameworks. Functional and clinical tools like cardiopulmonary exercise testing, CPET, New York Heart Association class, and diuretic dose are critical, especially in ambiguous cases or later stages of disease. The Cheng et al. Model, which integrates biomarkers, imaging, and clinical features, exemplifies the future direction, multimodal stratification that is more accurate and personalized. Bottom line? Combining biomarkers, imaging, and functional assessment delivers the most comprehensive view of disease severity and prognosis, something now reflected in contemporary practice guidelines. Understanding prognosis isn't just academic. It shapes patient conversations, informs treatment decisions, and influences outcomes. And that's where we're headed next. In the next lesson, we'll shift gears and focus on treatment strategies for transthyretin cardiac amyloidosis. We'll explore disease-modifying therapies, TTR stabilizers, gene silencers, and how treatment approaches differ across disease stages and phenotypes. So stay tuned, because understanding prognosis is only the beginning. The next step is changing outcomes. See you in the next lesson.